Morning, everybody. Thank you for the great introduction. This is the title of my presentation for today, Procedural Comfort in Care in Young Children and Findings from a Qualitative Study on Nasogastric Tube Insertion in the Light of Procedural Comfort Care. First of all, I'm not the only one working on this subject in Belgium. For this research project, we have worked together with three colleagues. You can see them here. It's my colleague Ine, Professor Piet Leroy from the Maastricht University, and Ine and myself, we are working at PXL University College, and we are collaborating with a lot of Flemish hospitals, university hospitals, and regional hospitals, where we share our knowledge and expertise. I will be discussing today three top subjects. I'm not so good in English. I'm not a native English speaker as my predecessor, but I will do my best. The first part is about the results of the nasogastric tube study we have conducted. It's a qualitative study. The second part is about procedural trauma, and then finally procedural comfort care. We also have some video materials in the mean part in the middle, so that will be a connection between the theoretical part and the more practical side of the project. So just to start off, when we had a lot of conversations and talks with people in the hospital world, it came across our attention that there is a lot of struggle these days in regard to placement of nasogastric tube insertions. There's a lot of research performed on placing IV catheters, needle procedures, and things like that, but always there's not so much research you can find on the difficulties of nasogastric tube insertion. And I've put in a little video here.
So, my name is Jo Vrancken. I'm one of the dietitians from the hospital. One of my colleagues partners had a NGP tube for a week. Quickly carried on with it. Now, unfortunately, people tolerate it very well, gagging and vomiting a lot. So he chose to have his NGP out. And so I said I would have them come out before him and see how I got on.
So if this guy's colleague, he's an adult person who is in good shape, in good health, he experiences a lot of difficulties with the nasogastric tube. So you should imagine that what would it be like for young children who are ill, who are critically ill, and who need to get a tube inside their nose to their stomach. So it has to be something rather invasive for these children. So it enhances a lot of pain and discomfort for the young children. So we conducted a study, a qualitative study, in order to get a good vision on what are the typical problems and the typical aspects of the nasogastric tube insertion. So what did we do? We formulated two research questions. First was, which challenges and complexities do healthcare providers and parents encounter in managing NGTI? That's what you call in the UK, NGTI, in children younger than 10 years of age. And second, what strategies might enhance NGTI success while minimizing trauma? So we performed a qualitative study. We did some focus group research. We organized two separate focus groups, and in these focus groups, all necessary participants were involved. We have on the right side here, we had some pediatricians, pediatric nurses, head nurses, pediatric nurses specialized in procedural comfort. We have them in Belgium. They are part of the PROSA teams. PROSA stands for Procedural Sedation and Analgesia. They are specialized nurses who work in regard to procedural comfort. We had a lot of parents in there of young children, child psychologists, nursing students, and a lot of researchers who participated in the focus groups. NGTI, what are we talking about? Well, everything is summarized here. It involves placing a flexible tube through the nose and the pharynx into the stomach. That's what we're talking about. And the indications, they are various. You can put it in there for nutritional support, rehydration, drainage, and things like that. You all know these indications, I presume. Annually in Belgium, 91,000 NDIs are performed. I have looked it up. In Great Britain, this number is much higher because it's a larger country. I think it's above 3 million placements per year. And it is considered one of the most uncomfortable medical procedures by clinicians. So not only by parents, by clinicians. And this is stated by research, which is pretty recent in 24. Our results. As we've done some qualitative research, we have gathered a lot of citations from parents, healthcare providers, pediatricians and things like that. And that is one of the citations that I want to kick off with. Seeing a child experiencing a lack of air, gagging, it's just heartbreaking. That's something that one of the pediatric nurses said to us in the focus groups. We've divided the results into the experiences of the different people involved in the study. First, the children's experiences. These are the experiences by children. They experience pain, gagging, it's a choking sensation, it's an escalating distress, especially when restraint is applied. To be clear, restraint means one of the parents or the nurse physically restrains the child on the table where the procedure is performed. In Belgium nowadays, a lot of procedures are performed still lying with the child lying down, when there is some scientific evidence that it's more better to perform procedures on the lap of the parent or maybe sitting upright. But a lot of procedures are performed lying down because it's more comfortable for the professional, not for the child or for the professional. And there could be some trauma from previous experiences. One of the nurses stated it happens in a very sensitive body of the sensitive region of the body. It's in the face, which is very sensitive, and we lack additional solutions to provide comfort. So I think that's a general problem in regard to this procedure. And also, if the first one goes wrong, then it's hard to make it comfortable for the child the next time. So you only have one chance to put it in a correct manner with less traumatic experience. So it's rather important that you perform it good the first time. I've looked up some social media, and when you look at social media, there are some YouTube channels, there are Instagram channels. These are all citations from people who experienced nasogastric tube insertion when they were a child, and now they are adults. And you can see it aligns with the experiences that our children in the study stated. Like you see, it's highlighted. They say it's the most painful experience ever. Something got stuck in my throat. I was scared. I panicked. I pulled it out. I felt I was being choked. I didn't have a good experience. I had nosebleeds, gagging, tears in my eyes. It took my general GI 3 appointments just to try and get it in. So these are all some experiences by people who have had a nasogastric tube insertion. So it's something that we need to raise attention about. It's not something for us as professionals, just put in the tube there, but it means a lot to children, as you can see here. The parental experiences, well, they say that watching your child suffer is a burden, and they are always in the doubt between I need to protect my child versus the procedure I want it to go on, because if it's more quickly performed, then we can go home rather quickly. So they always are in imbalance between those two things. They want to protect, on the other hand, they wanted to get on with it. And after placement, they have fear of tube dislocation, because if a child pulls it out, it needs to be put in again. So the parents are in stress. The children have a loss of appetite after the placement, and they all say that the child looks very ill, because compared to an IV access, which is rather discreet, a nasogastric tube is in the face. It sticks there with the tape and all these things. So it gives an opinion that your child is really ill. And that's something that the parents experience a lot of times. Also, the parents experience uncertainty or distress from professionals. There is a lack of clarity in the approach. What about the parental role? All the parents say, please give me a task during placement. Let me do something. I want to be helpful. But a lot of professionals, they don't have attention for the parent. They just perform the NGTI, but the parent is a powerful partner in a procedure. So you could give them a task and let them do something. Waiting times. Why can't nurses tell us why they return more precisely, and why do we have to wait? When a nurse enters the room and they say, I'll be back, and there will start. But they don't tell you what they are going to do. When will they be coming back? Does it take 15 minutes? Does it take an hour? The stress in the room with the child, it builds up. And it builds up highly. And then when somebody enters the room, then all hell breaks loose, and then they are in panic, because then this is going to happen. So we need to address the waiting times. And finally, there are a lot of interprofessional discussions. I think we all know that. As professionals, we discuss our job, but we should not discuss this job when we are working with the child and the parent, because they are already stressed. Here, are you already ready? Are you almost ready with your task? I need a second hand for this NGTI. Those are things that they hear. There are other things as well, but they hear professionals talk about the procedure that needs to be performed. And they don't want that. Parents say that that enhances our stress. So we need to be aware of that also. So the healthcare providers' experiences, well, they say it's an emotional toll of causing pain and stress with a child. And there's a lot of frustration with repeated procedures. At night, when you're alone in the ward and the child pulls out the tube, but it needs this feeding, yeah, you're stuck all alone and you need to put it in there again once more. And you're alone for this procedure. It's so frustrating when the child pulls it out. Unintentionally, of course, or maybe intentionally. You have to do it all again with all stress and all the discomfort. There's pressure from time and staffing constraints. Performing NGTI needs dedicated time, focus, and of course enough personnel. Maybe there's a need of 2 nurses or a pediatrician and a nurse who perform the procedure, but these are often missing, especially in emergency care departments. We don't have the time. I don't know how it's in the UK, but in Belgium, we hardly have any time on our nursing wards and on the emergency department, and we just want to get on with it and keep the flow going. There are some systemic challenges, lack of consistency and consensus and consistency. There are a lot of local beliefs toward the technical aspects. Some people say you should always put in a mandrel. A mandrel is something like that. It's a guide wire. Other people say, no, you should never use it because it causes a lot of pain and it's more rigid in the nose. Some say you should use a pre-warm tube. Others say you should put in a pre-cooled tube because cooling gives you some pain relief in the nose, and the warm tube is more flexible, so it's easier to place. Some say you should put it in quickly versus gently and very slow at the tempo of the child. Should we use lidocaine lubrigel, or should we nebulize it, or should we use anything? There's a lot of inconsistencies in this also. And then, of course, how about fixing the tube? Some wanted to fix it on the front side of the nose, some want to fixate it on the jaw, some want to fixate it on the back. There's a lot of discussions on that as well, and there's no consensus on this. Here you can see an example. This child has a nasogastric tube. You will see her in the video in a few minutes. And she wanted her nasogastric tube connected to the ponytail. So the mother connected it to the ponytail, as you can see here. And when the feeding needs to be done, it's the nurse is standing behind her and she can start the feeding. So there are some very interesting insights on that matter, which we can apply in the future protocols. Also, indications and urgency. It was a consensus in our focus group that NGTI is rarely urgent. You need to take this with some consideration, because when it's urgent, we don't mean it has to be put in now because otherwise the child is dying or it needs to be fed now. But the urgency is rather in case of it can be placed in within an hour. Yes, but then 2 hours is fine also. You can do it on a more convenient time moment during the admission of the child. It doesn't have to be right now exactly. Usually you have a time window. And is there a child-friendly approach? And is there attention for procedural comfort? A lot of times these things are missing, and which is rather not good for the child. Here on the upside, underneath the blank belt, you can see that is in emergency departments, there is rarely attention for comfort and for timing and for child-friendly approach. So we need to be aware of that. Resource constraints, time personnel constraints, adequate preparation and child-centered performance requires time. In the absence of time and staff, we often have no choice than to overrule the child. Overruling means we need to contain the child and constrain it. It's against our moral ethics, but we do it. We sometimes do it. And the people who do it, they think it's not good that they do it, but they need to do it because they feel obliged because the tube needs to get in there. And then material availability. Some people, they want to experience, they want to put in the nasogastric tube under Calinox. Calinox is nitrous oxide, but they lack nitrous oxide in their hospital because they don't have sufficient scavenging of the gas. So they don't meet the regulations in the hospital, and therefore they cannot apply nitrous oxide, which is doubtful because it can be a good strategy to use when you perform NGTI. So material availability is something that needs to be in account as well. So we need to be changing the paradigm. We have concluded 4 guiding principles in our study. The first principle is do no harm. So we should reassess the indications and urgency of NTI, and we should always consider alternatives. Like for instance, maybe we can use oral rehydration in case of rehydration. Maybe we can use a spoon and some fluids and get the child drinking on that way. Maybe it takes a lot more longer, but maybe it's also efficient. The principle 2, slow down and take the time. We should prepare the child and the parent. We should regulate our professional emotions before we enter the room. If we are stressed as a nurse because we need to perform a highly complex procedure, and we are distressed, we enter the room, we give our stress to everybody in the room, and they don't deserve that. They deserve a calm and professional nurse who executes the procedure. Principle 3, NTI is more than inserting a tube. We should use a team-based, child-centered approach, including child life specialists. In Belgium, we don't have a lot of them, but in some university hospitals, we have them. So when they are present, we should always use them to do these kinds of procedures. We use distraction techniques, comfort positioning, and pain relief. Those things are very important. And finally, we should debrief and learn. We should always do a debriefing with the child and debrief as a team on which strategies seem successful for NGTI in young children. So for the conclusion of our project, we stated that interdisciplinary collaboration is very important. We should use standardized protocols containing a lot of aspects that we can use with children. These things we can do, and these things we don't do at this hospital. So we need to put it in protocols. We need a lot of education and training of our nurses and further training. It's not because you are technically skilled in putting in an NGTI that you also are skilled in connecting with the child and providing comfort care. So you need to be aware of that also. And finally, we should use resource-conscious strategies like comfort strategies that are questioning NGTI, the indication for NGTI, the timing of NGTI. We should make appointments on that matter as well. So as promised, I have some video fragments of NGTI in practice. This is a video that we have made very recently, therefore it was just uploaded. So we've analyzed it. I've put in some undertitles. Hopefully it will be good because it's spoken in Dutch, of course. What you see here is the nurse removing the tape of the nasogastric tube. It's a child with a severe eating disorder at this moment. She's very anxious. She has a food intake problem. She's very anxious for gagging, for choking. She has some aversions, and she's very anxious. She already had one nasogastric tube placement, as you can see. It was not so easy, and they've performed it with midazolam. She was sedated, and that's what they have applied here as well. That's why she's a bit sedated at the moment. And now you can see the first tube is removed. Mom is present. It went fine, it went okay, but you can see that emotionally, she's having a very hard time at this moment. So what you saw here, she has a lot of emotions from the previous NGTI. And this procedure has a meaning for this child. It means a lot. It means she has had a lot of stress, a lot of discomfort, and she takes it all with her to the next time that the procedure needs to be performed. So what the nurse and the mother did, they established a lot of trust with the child. So that was, you could see that the nurse sat down, she was very at ease, she comforted the child, she had a good approach. So it went fine, the removal of the first tube. Then the second video. Here. They ask her which side she prefers, but she has a little, how do you call it? Little injury here from the previous. She prefers the other side. That's the second skin they provide. Now the nurse is going to apply some lidocaine in the nostril by nebulizing. She's explaining what is going to happen. They explained it before. She's keeping up quite well. She's doing her best. So what you see here is a very child-friendly approach. You see there's a lot of attention procedural comfort. There's pain prevention by the lidocaine. And you see they are establishing trust and maintaining trust. As principle 2 of our study concluded, slow down, take the time, prepare the child, and prepare everything, and enhance procedural comfort. The third video, that's the placement of the tube. So they have waited until the lidocaine has the time to work, about 5 minutes. And then she can choose her song. She doesn't like to be distracted by books or by iPads or by bubble blowing. She just wanted to some music, and yeah, Lady Gaga. She's a big fan. So they are looking at the video screen and selecting some music videos from Lady Gaga. So this is also a very child-friendly approach, providing her choices, creating control with the child, and maintaining trust. So this is a team-based, child-centered approach, including mom, the specialized nurse, in order to get the right comfort in the room. Spanish is not okay. She doesn't like Spanish. So this was the third video. Now the fourth video is about the placement. This is the placement of the tube. It's a bit longer, but I'll keep it going. She already had one tube, so she knows she needs to drink at some time. She has to swallow. The nurse explains it very well to her. And you see the child is very calm. That's because of the midazolam, of course, a little bit. It has worked. Now she's measuring. You see, she doesn't like that. She's afraid. She doesn't want to sip. So the nurse asks, can I start with the procedure? And she says yes. So she has the permission of the child. Hey, you can do it now. I'm ready. So she's following the child's rhythm. Mom's involved. And you can see this is a procedure which is going very respectful for the child. And then start putting in the tube. She doesn't feel pain because the nostril is anesthetized. Bit difficult there, so wait a bit. And we'll go further. So all the stress coming out, of course, emotions. And now mom is going to make the ponytail. So they're wrapping up now. She can come to her positive again. Calming down. So you can see here the very child-friendly approach, which is very important. And then the final video, the post-procedural care. You can see she's being comforted by mom. And then there's a moment which the nurse is going to reflect with the child. Everything. So, and then they make a plan for the next time because she needs to come back and she needs another nasogastric tube. So I think we can all agree that this was a successful procedure in which a tube got in and there was no trauma and everybody performed well, but it was not an easy procedure for this child. It was very distressing for the child. It was not so painful, but it was very distressing. And when you address the pain and you address the discomfort, then you have a good chance that there's no trauma. But when you don't, then we can cause procedural trauma in children, and we need to avoid this at all times. When we cause trauma, there's always a triad of these things. There's always attention for pain, there's fear, and there's focus. When these three aspects are present, then we can have distress during a procedural, and we can have procedural trauma. In regard to pain, this is also very interesting. Doesn't seem to work. Nope, it's no problem. We have the study here from Anna Telio in the late 90s. And she performed a study on neonatal infants, on youngborns, and they performed a circumcision here without anesthesia. And what you did see is when the children were immunized, vaccinated after a few months, then there was a big difference between the children who are not circumcised and the children who are circumcised without anesthesia. You can see here that the cry duration and the pain scores are much higher with the children who did not get anesthesia during their circumcision. So it means that there's something happening in the brain. So there's a memory for pain. So pain, it settled down in the brain and you can take it with you during medical procedures in the future. So that's something that we need to be aware of. Second part is fear. There are a lot of factors. This is a good scheme by McMurtry and et al. In 2015. These are all factors that play a significant role in the development of fear. It's a model for painful procedures, needle procedures, but you can also put it through to nasogastric tube and other procedures. There you can see in the middle is the infant, and there's the development of pain and fear. And you see on the left underside, they're predisposing, participating, perpetuating, and protective factors, which play a role on the fear. So like, for instance, a parent who is very anxious, or the unknown, or no trust. Those are all factors who play a significant role on the child. And then in order to overcome these things, you need to put in there some interventions, like pharmacological interventions, psychological interventions, and also other interventions in order to overcome the fear and not let it grow into adult and parent fear and pain. Focus. If the focus is on pain, then it will increase. Like when you put the needle inside of the child or you put the tube inside of the child, of course, it will be highly distressed, the child. And then finally, restraint. I think everybody agrees that this restraint in children is not a good strategy. There's some interesting research by Benedict Lombard, and she calls it the transient empathic blindness. It seems that we as healthcare providers, we have the capability of temporarily blocking our empathy with children and overcome our empathy, and we do restrain children in order to get the procedure performed. So she calls it transient empathic blindness. So for further reading, you can all find the resources in the presentation. So procedural comfort care, we need to address all these things in order to overcome procedural trauma. And we have a good scheme for that, a good model. This is the 7P model by Leroy et al. 2021. And these are 7 things that you need to take into account with every medical procedure that you perform in young children. It's very, only 2 minutes and then I'll be ready. So the first step is, what does this procedure mean for the child? We saw the girl with the nasogastric tube. It means a lot for her. So, but you need to address this. You need to make a connection with the child before content. You need to connect with the child and know, what does this procedure mean for this child before you go and put in a nasogastric tube? So some questions here. What does the child already know? Were there previous experiences? And then you can make the right decisions in order to get your approach right. So that's step 1. In step 2, we need to raise the question, is it really necessary right now? In case of this child, it was necessary because she needs to be fed. So we cannot wait any longer, but maybe we can, in other times, we can postpone the procedure in order to get a more optimal moment. Step 3, psychological and cognitive strategies to increase trust. Yeah, making hospitals less scary for children's hospitals, using distraction and things like that. We have a lot of examples there, like providing predictability, desensitization, letting children get familiar with medical materials. It helps a lot. Giving good explanation to children, like the anesthesia mask induction here. You can see it on the right side. Also, we do it at our PXL University School. We invite toddlers and preschoolers to our school, and we let them get familiar with medical procedures, like syringes, like things, all these things, like beds. So in order to reduce their anxiety when they need to go and visit grandma at the hospital, for instance. Avoiding negative stimuli and the one voice principle. Here on the left side, you can see an emergency department where the focus of the child is on the needle. There's a lot of bright lights and everybody is talking across the child. And he's very anxious and his father needs to hold him down. On the right side, you can see a very at ease room with dimmed lights. Only one person talks to the child, and it's a very friendly environment, which is very more at ease for the child to perform the procedure. Comfort positioning, I've discussed this already, over that. Easy breathing, and of course, positive appraisal. Every child performed very well, and they all are rewarded for their effort. Even if they are crying, that's okay. You should praise the child. You were crying, yes, it's correct, but you kept still, so that's very good. So there's always something that the child has done great. The right focus during the procedure. This is interesting research by Baruch Kraus. You can see all these physical comfort measures, and here on the other side you have distracting strategies in per adult stage. And for our child with the nasogastric tube, she enjoyed music and she enjoyed Lady Gaga. So whatever works for the child, we can try to put it in there in our approach. Pain management, you know a lot of these things, but we can always do something. With every procedure, we can always do something to prevent pain. We have EMLA, we have lidocaine, we have intranasal, we have topical. We have a lot of these things, but we need to apply them when we can. So that's very important. As a matter of fact, we should never perform procedures when no analgesia are provided in children. 5, the procedural process. How are we performing? How are we organized? Very important to think about that as a team. And then we have the rights-based standards. Maybe you know these by Lucy Bray. Those are developed in 2020, I think 23. Yes, 23. Children have rights at hospitals. Children have the right to have a professional cared for her who has the appropriate knowledge and skills to support their physical, emotional, and psychological well-being. the children don't have the right only to have somebody who is experienced in bringing in a nasogastric tube. No, it should be someone who also has a good knowledge of psychological aspects and connecting with the child. So the rights, you can find them in the attachment of this lecture. And then we have procedural sedation, a lot of possibilities. Like, for instance, now we have these nebulizers who give this mist. Like in previously, there were these nebulizers who, when you put it in there, it's a harsh beam. Nowadays, these are all these gentle mists, and children don't experience this as hindering. So that's very good. And you all, yeah, of course, with the gas, the nitrous oxide, you can also use that, of course. For procedural sedation, there are a lot of research papers on this one, but this is one of the best, I think. As you perform procedural sedation in young children, you need to have knowledge, skills, and training as professional. You need to know what you're doing, and you need to know how far can you go and what can you perform. So this is a good work by Lavoie and Krauss in regard to this, addressing these professional competencies. And then finally, post-procedural care, very important. What went fine, what went less fine, and we make the foundation for the next time that the child needs to come back to the hospital. This is what they did great with this child. They connected with her, and she said everything went wrong. Okay, so what can we do next time? What can we optimize? So that was that. So big thank you.